Welcome to Section 5 of the Renal Physiology Review. In Section 5, we will go into more detail on the evaluation of renal function, including introducing the concept of clearance, how to measure clearance, as well as calculating renal blood flow and filtration fraction. Welcome to Section 5 of the Renal Physiology Review. In Section 5, we will walk through the evaluation of renal function, including the concept of clearance and how we measure glomerular filtration rate. Renal function is considered the rate at which the kidneys filter and remove toxins from the systemic circulation. The key concept to remember is how clearance is measured and its relationship to glomerular filtration rate. Let's walk through once again the concept of clearance. Clearance is defined as the volume of plasma from which a substance has been completely cleared by the kidneys per unit of time. If a substance is freely filtered across the glomerulus and neither reabsorbed nor secreted in the tubule, then the clearance of the substance equals exactly the glomerular filtration rate. We estimate glomerular filtration rate using the clearance of substances that are freely filtered, but neither secreted nor reabsorbed along the tubules. Clearance is a volume per unit time, and again, it's the volume of blood or plasma from which a substance has been completely cleared per unit time. The clearance of a substance provides useful information about how the kidneys handle that substance. This is it filtered completely? Is it filtered and reabsorbed? Filtered and secreted? If the clearance of a substance is greater than the GFR, it implies that the clearance must be dependent not only on filtration, but there also must be secretion. However, if the clearance of a substance is less than the GFR, it implies that all that is filtered, a portion of that is then reabsorbed. Let's walk through a sample calculation of clearance of a substance. While it is unlikely you will have to carry out a clearance calculation on the US Assembly Step 1, it is important to understand the concepts in case it were to come up. As we said, the clearance of a substance from 100 mL of blood per minute will result in 1 milligram of substance being excreted into the urine each minute. Clearance times the plasma concentration of a substance equals the amount excreted per unit time. If we rearrange the equation, clearance equals the amount excreted in urine in 1 minute over the plasma concentration. If the amount excreted in the urine in 1 minute is 1 milligram per minute, and the plasma concentration is 1 milligram per 100 mL, then the clearance of that substance is at 100 mL per minute. We express this in terms of urinary flow rate and urinary concentration. We have the clearance equals the urine flow times the concentration in the urine over the concentration of the plasma. Milliliters per minute equals the urine flow in mLs per minute times the concentration of the substance in the urine in milligrams per milliliter over the concentration of the plasma in milligrams per milliliter. The important equation to remember is the urine concentration times the volume of the urine over the plasma concentration, or UV over P. Let's use a specific example, being urea. Let's take the example of a plasma concentration of urea being 0.2 milligrams per ml. The urine concentration is 15 milligrams per ml, and the urine flow rate is 1 ml per minute. Once again, the urine concentration times the volume and the flow rate over the plasma concentration. 15 milligrams per ml times 1 ml per minute over 0.2, which equals 75 mL per minute. Note that the clearance for urea is slightly less than the typical GFR. We said the normal GFR is approximately 100 mL per minute. This is consistent with net reabsorption of urea along the nephron. In order to determine the clearance of a substance, you need to know two things: the plasma concentration of the substance and the urine concentration of a substance in a timed urine sample, because this gives you the urine volume and the urinary flow rate. Clinically, creatinine clearance has become the most common surrogate marker for GFR. Let's walk through a few of the basics of creatinine. Creatinine is a breakdown product of skeletal muscle. It is released constantly in the bloodstream, and the release rate is proportional to the muscle mass. The kidney handles creatinine in the following way. It is freely filtered across the glomerulus. It, unlike urea, is not reabsorbed, but it is slightly secreted, the amount of secretion increasing as the GFR falls to low levels. Because of the slight secretion, creatinine clearance is slightly greater than GFR, but because of its ease of measurement and standardized formulas, it is used as an approximation of GFR in clinical practice. The calculation of creatinine clearance is as follows. First is measure the creatinine in the urine collection, which is the urine concentration of creatinine times the volume of urine. The amount of creatinine filtered, then, is the plasma creatinine times the GFR. If the GFR is equal to the creatinine clearance, then the GFR is equal to the urinary concentration of creatinine times the urine volume over the plasma concentration of creatinine. Once again, UV over P. Creatinine clearance is used clinically as an estimate of GFR. Because of the slight tubular secretion of creatinine, it is a slight overestimate of GFR. Also, when drugs are administered that may affect how creatinine is secreted, drugs such as trimethoprim, which is involved in trimethoprim sulfamethoxazole antibiotics, or cimetidine, which both inhibit creatinine secretion, serum creatinine can go up, underestimating GFR. That if GFR decreases, plasma creatinine will increase until a new steady state is reached, at which point urinary excretion of creatinine will match daily creatinine production. In terms of the clinical application, do clinicians routinely measure a creatinine clearance by 24-hour urine collection? Rarely, because this requires a timed urine collection, which is generally considered to be a nuisance and logistically too difficult. Instead, we typically use plasma creatinine concentration as a surrogate marker of creatinine clearance and therefore of GFR. Some important caveats to the use of serum creatinine concentration as an estimate of GFR. In order to estimate GFR, creatinine levels must be at equilibrium, i.e. fairly constant, and creatinine is not an accurate measure of renal function when renal function is changing rapidly. For example, if one were to take a healthy individual, the normal serum creatinine concentration is approximately 1 milligram per deciliter. This would correlate to a GFR of approximately 100 mL per minute. However, if you took that healthy individual and removed both kidneys, the GFR falls to 0. However, the serum creatinine concentration would not reflect this immediately. It would take many days until the creatinine concentration would rise to reflect this GFR change. This is an extreme example, but serves as a point to highlight the limitations of the measurement of a single serum creatinine in a setting of changing renal function. When renal function is changing, the trend of the creatinine is more important than a single value. In terms of the clinical application, the basic idea is that creatinine is proportional to the inverse of the GFR. Very roughly, a normal creatinine is 1, a normal GFR is 100 mL per minute. Creatinine of 2 implies a GFR is half normal, or roughly 50 mL per minute. Likewise, creatinine of 3 implies a GFR of approximately 33 mL per minute, and etc., etc. As the creatinine increases, GFR falls. Important to note, however, that the change from 1 to 2 in serum creatinine is not the same as the change from 2 to 3. We said these changes are proportional. The change from 1 to 2 implies a halving of renal function. However, a change from 2 to 3 does not indicate as much of a decrease in renal function. Rather, only 17% of renal function is lost. Although the numbers may change by the same value, it does not reflect the same change in GFR. To go through this again, because creatinine and GFR are inversely proportional, an increase in creatinine from 1 to 2 represents a much more significant drop in renal function than an increase of 4 to 5. Creatinine rise of 1 to 2 implies a 50% drop in GFR. Creatinine rise of 4 to 5 implies only a 20% drop in GFR. As GFR drops, a greater proportion of creatinine is excreted by secretion. Therefore, creatinine clearance becomes less accurate as an estimation of GFR, and will in fact begin to overestimate the true GFR. Some other drawbacks of relying on serum creatinine. As we said, creatinine source is in muscle mass. Therefore, with extremes of muscle mass, this will change the concentration of creatinine, which may change the estimation of renal function. This is especially true in individuals with low muscle mass, such as an elderly old woman. This will give you a false impression, an overestimation of renal function. On the other hand, when you have a young, very muscular male, especially with high muscle mass, serum creatinine concentration will be higher, and this will underestimate the GFR. In the clinical realm, creatinine by itself has been replaced by estimations based on calculations. The two calculations primarily used are one called the MDRD and the Cockcroft-Gault. The details of these equations are not important to remember for USMLE Step 1, only that they exist, and they are used often to convert serum creatinine into an estimated GFR to correct for potential overestimations or underestimations based on changes in age, race, or gender. One thing that is often asked on the USMLE Step 1 exam is the experimental calculations of renal function. We've talked already about how the clinical estimations of creatinine clearance and clearance as a whole are imperfect. Ideally, to estimate glomerular filtration rate or renal clearance, you'd like a substance that is freely filtered, not secreted, and not reabsorbed. The substance inulin fits this role. However, inulin measurement and clearance of inulin is impractical to do in the clinical setting. Nevertheless, it is important to remember that inulin clearance best approximates GFR. Some of the other calculations that the USMLE Step 1 exam focuses on are the concepts of renal blood flow and filtration fraction. Renal blood flow is equal to the renal plasma flow plus the non-plasma components of blood. An easy estimation of renal blood flow is approximated by the renal plasma flow divided by 1 minus the hematocrit, essentially the proportion of blood that is not contained in the red blood cell mass. Renal plasma flow could also be estimated by the clearance of a substance that is completely cleared in a single pass, meaning that with one cardiac output, with one cycle through the renal tubules, the substance is completely cleared. The substance para-aminohippuric acid, or PAH, fits this role. It is a substance that is freely filtered and actively secreted by the proximal tubule. Because of that, it is cleared completely in a single pass. Therefore, renal plasma flow is approximated by the clearance of PAH. Filtration fraction is another concept that is often asked on the USMLE Step 1. If you recall, the filtration fraction is equal to the GFR, the glomerular filtration rate, divided by the renal plasma flow. Oftentimes, USMLE Step 1 questions will give you the clearance of inulin and the clearance of PAH. Using these two, with the equations outlined previously, we can estimate the filtration fraction. by using the clearance of inulin, which approximates best the GFR, divided by the clearance of PAH, which best approximates the filtration fraction. As we have stated already, the filtration fraction normally is between 15 and 20%. These equations, and remembering that inulin best approximates GFR and PAH, and the clearance of PAH best approximates renal plasma flow, are extremely important to remember. As I said, oftentimes USMLE Step 1 questions will give the substance's concentration in the urine as well as in the serum, ask you to calculate clearances, and then make further conclusions about filtration fraction, renal blood flow, or renal plasma flow. This concludes Section 5 of the Renal Physiology Review. The key points to remember in Section 5 are how to calculate clearance of a substance, that creatinine is used clinically as an estimation of GFR, and the drawbacks of using creatinine in this fashion.